Assalamu alaikum and good morning. My name is Dr. Shazia Maqsood. Today's lecture is about preterm labor. We are going to talk about the causes of preterm labor, the risk factors which causes preterm labor, and also the management of preterm labor. The most important thing that we would learn today, the key take-home messages, would be that it is an ongoing problem in the developing as well as underdeveloped world. There are a lot of burden in terms of financial losses on healthcare providers, as well as a lot of mental stress on parents when a preterm baby is born into a household. So today we are going to learn about how to check for the risk factors, how to examine a lady who comes with a possible preterm labor, how to prevent a preterm labor, and how to manage a person with preterm labor and perhaps try to save the baby. So by definition, the onset of labor before 37 weeks in a pregnancy beyond 20 weeks is called preterm labor. Before 20 weeks, it's termed as a miscarriage. After 20 weeks and any time up to 37 weeks, it is termed as preterm labor. Term is after 39 weeks or 40 weeks. There are different definitions. By UK definition, we take the lower cutoff as 24 weeks. By the USA and by the FIGO definition, the lower cutoff is 20 to 22 weeks. Overall incidence of preterm labor is about 6 to 10% all over the world. And in most of the cases it's spontaneous, the cause is not known, and that determines for about 40 to 50% of cases. In about 25 to 40% of cases, the lady would represent with a premature preterm rupture of membranes. And about 20 to 25% of cases of preterm labor are attributable to obstetrical reason, and we'll discuss that. It could be a medical reason, it could be a high-order twin or triplet pregnancy, etc. So as we were talking about, all over the world, the preterm births are, a big nuisance, a big menace, a financial burden on the healthcare providers. So worldwide range, it really does not matter much whether it's a high income country or a middle income country or a lower income country. All stratas would suffer similarly with preterm births, albeit a little bit more with the lower income strata where there are nutritional deficiencies in the mother. So what are the hazards of preterm labor? So if you can think about delivering a term baby, like a 3 kg baby or a 4 kg baby, the baby is fully developed. The brain of the baby, the lungs of the baby, the viscera, the organs of the baby, the intestines of the baby, the eyes of the baby, the hearing of the baby are all fully developed. But in a preterm baby, the problem is that the baby may have behavioral problems or ADHD, may also suffer from cerebral palsy if the brain is not fully developed, can have asthma, can have bronchopulmonary dysplasias, can have intestinal problems, especially a big nuisance is a necrotizing enterocolitis, and can also have pneumonia, can have vision problems, can have hearing loss. So these are very, very common things with a preterm premature baby. So in comparison to a preemie baby versus a full-term baby, the preemies may have more respiratory distress and breathing problems. At 35 weeks, the baby brain still needs to grow 50%. So if a baby is born 31 week, you can imagine, you can expect some developmental milestone delays in such a baby. The baby may not have enough body fat to regulate the temperature until 34 weeks. So if baby is born like 29 week, 28 week, that baby will need special care, baby unit care, and cannot be sent home. So very important issue in that sense would be if somebody comes with a preterm labor, then that person needs to be admitted and that baby needs to be delivered in a unit where there is facility to look after such babies. Such babies also have problem with feeding because of the sucking reflex or the swallowing reflex is not fully developed until the 34th week, and hence may need nasogastric tube feeding for a long, long time. So our topic today, we will talk about sign and symptoms, we'll talk about risk factors, we'll talk about the diagnoses, we'll talk about prevention and management of preterm labor. So let's talk about signs and symptoms of preterm labor. Any lady who comes with a vaginal discharge, an odor, watery or mucousy vaginal discharge, do not ignore that. Examine that lady. She could be having a rupture membrane. She could be having an infection causing chorioamnionitis resulting in preterm labor. So the most important sign that the lady would tell you, or a symptom that the lady would tell you, is that she's having a vaginal discharge. Also, a feeling of pressure down below in the pelvis or abdomen, something feeling very heavy down there, or a constant dull ache in the lower back, or mild abdominal cramps, perhaps a bit of stomach upset with diarrhea, and then actual contractions ensuing, often painless with the waters breaking. These are all signs and symptoms of preterm premature labor when it is not the date. So what are the risk factors for the preterm premature labor? The most important risk factors are if there's a prior history of premature birth, that person is about 10 to 20% susceptible to have another preterm birth. If it is a multiple high-order pregnancy, vis-a-vis a twin pregnancy due to overdistension, a triplet pregnancy due to overdistension, or infection, for perhaps, can also end up in having a preterm labor. There could be a family history. Somebody in the family, first-degree relative, has had a previous preterm birth. There could be a maternal health condition like high blood pressure, preeclampsia, diabetes, blood clotting disorders, all of them causing intrauterine growth restriction and necessitating delivery before 34 weeks. Also, weight problem before pregnancy or gaining too much weight during pregnancy can also give rise to preterm labor. Smoking is also a contributory factor. So are illicit drug abuse, maternal age, either very young or older than 35, and then stress, prolonged high levels of stress. You may have heard that somebody had a bereavement in the family and she was very stressed and she went into labor. So that's how bad stress can be for these mothers. Okay, so how about the diagnosis of preterm labor? So if somebody is coming to you whose due date is not yet there, and she complains of regular uterine contractions, at least 1 to 2 contractions every 10 minutes, they need to be assessed for preterm labor. They need to be examined, and if the cervix is dilated more than 2 centimeter and the cervix is softened up or taken up, or which is called effacement of the cervix, is about 80%, it means that person is going to go into labor imminently. So we have certain modalities to diagnose if we are suspecting a preterm labor. We can do some vaginal testing via some strips, which are called fetal fibronectin testing or placental alpha microglobulin testing. And we can also do an ultrasound, a transvaginal ultrasound, to check the length of the cervix to see if there's cervical shortening or cervical funneling, which will imminently cause the lady to go into preterm labor. Now, the problem with this is that, lady can deliver, no problem. But if the baby is too small, say for instance, if the baby is 27, 28 weeks, the baby's lungs are going to be too much premature. The baby will not be able to survive well outside in this world. So we need to, even if somebody is going into imminent preterm labor, we have some medications rolled up our sleeve which can at least be given to the mother in a best hope, so that they can mature the baby's lungs and brain to a certain extent, so that when the baby is born, the doctors can look after the baby and the chances of survival will be better than if not given those medications at all. Okay, so the diagnosis, let's revise it a little bit. Abdominal pain, low dull backache, contractions, menstrual-like cramp, pelvic pressure, a bit of a bleeding or spotting, and a vaginal discharge that is heavy. So take a full history of the sign and symptoms, take a full background social history, make sure she's not a smoker, make sure she has not had any preterm labor before, make sure she's not having infection, inquire about her nutrition, check her weight, check her hemoglobin. So how do we diagnose? We can do a speculum examination. That's the best, quickest diagnosis. You do a speculum examination like in the picture given, and you can check the cervix directly if there are bulging forewaters, or if you feel that the cervix is effaced and open. That is a direct diagnosis. Or sometimes you can actually see the water leaking, so that's the direct conclusive evidence. At the same time, when you're examining, this should be make sure that this is a sterile speculum examination. You use sterile gloves and sterile speculum, and you will do swabs for infection screening. And what are the two main infections that we are screening for? These are the group B streptococcus as well as bacterial vaginosis. So these are the two swabs that you will take for infection screening. Apart from that, you can also do specific testing to see if she is at high risk of labor. And we'll talk about it in the coming slides. So there is a test called Amnisure. This is very widely available. It is a rapid and a reliable non-invasive test, similar to having a speculum examination. Check, open the speculum inside the vagina and put in the swab, and then take the swab, rotate it gently inside the vagina, and then put it in the small tube with the fluid provided. You put the strip in that tube as well, and then wait for 5 minutes. So if it is giving 2 lines, it means her membranes are ruptured. If it is giving just a control line, it means the membranes are not ruptured. So that is a very quick way. While the lady is on the examination couch, while she's dressing up back again, you have the result then and there, so you can tell her whether or not her waters are broken or not. Because sometimes the water may not break with a gush. There might be a little bit of a trickle, and this is the kind of a test which will tell you that it is surely broken or not broken. Okay, there is another very brilliant diagnosis, a bit recent now. It is called Partosure. Again, 5 minutes. Again, the same principle, again, 2 lines giving. These are the results that if the Partosure is positive, that means that that lady will go into preterm labor soon. So that is also your diagnosis, on-spot diagnosis within 5 minutes, that will tell you that this is a case for preterm labor and for admission and for further management. Okay. So then the next thing comes ultrasound. On the ultrasound, you can easily check the cervical length. All gynecologists should be familiar with these kind of ultrasounds to do a transvaginal ultrasound. All emergency departments who deal with gynae emergencies should be equipped with an ultrasound machine with a transvaginal probe. And what it does is that it gives you a certain certainty whether or not the cervix is closed, or whether the cervix is open, or whether there is funneling, or whether the membranes are bulging. So it gives you a very clear-cut idea. So that helps the diagnostician, that helps the obstetrician to determine whether we can tie the cervix or we can cerclage the cervix to prevent the preterm birth from happening. So this kind of ultrasound is a very spot-on diagnosis. It is a very accurate diagnosis. And if somebody is diagnosed with the preterm labor on the basis of ultrasound, which means if the cervical length is less than 1.5 centimeter or 15 millimeter, it's sure that she's going to go into preterm labor, because the normal length of the cervix is about 3.5 to 4 centimeter. Okay, so how can we prevent this then? Again, if you want to, the most important cause for preterm births, as we said, is infections. So do an infection screen early in pregnancy to make sure that you're treating them. Educate the ladies, try to give advice against smoking, against illicit drug abuse, highlight if there is any domestic violence or any stress factors in her life so that they can be addressed beforehand. Okay, so how about the prevention during pregnancy? So during pregnancy, if somebody has had a previous preterm birth, or if somebody is at risk of preterm labor, then giving her progestogens are very, very beneficial for increasing the window of delay while you are giving steroids to the lady to boost up the baby's lungs, while you're giving some magnesium sulfate to boost up the baby's brain development. So these kind of medications, the progestogen medications, are very, very good in delaying the preterm labor to at least a few days to up to about a week or few. So definitely this is the first line of management in a preterm labor. While you're waiting for any results, give her an injection of progesterone, or give her suppositories of progesterone, or give her tablets of progesterone. So, a history of spontaneous preterm birth and mid-trimester loss between 16 and 34 weeks of pregnancy, and a transvaginal ultrasound between 16 and 24 weeks of pregnancy, showing a cervical length of less than 2.5 centimeter or 25 millimeter, is a certain indicator that somebody can go into preterm labor. And these are the cases where you can start the progestogen and treat the patient on an outpatient basis. Such patients may not need an admission yet. Okay, so let's take a look at these management medications that we have available. So once you have diagnosed the preterm labor and you are planning to admit the patient, you are going to inform your senior consultant. You are going to inform the special care baby unit or neonatal intensive care unit so that they are prepared for the preemie arrival, as well as you will inform the anesthetist, because you may need to deliver this lady with a cesarean section, not a normal delivery. We'll talk about it in a bit. And you will admit this lady to a high dependency unit, not in a ward. Why? Because you will need one-to-one care. You will need frequent fetal monitoring with ultrasound and CTG. So the medications that you will give to this lady is A, antibiotic, and the antibiotic of choice would be erythromycin or ampicillin, augmentin, coamoxiclav. So this is for prevention of chorioamnionitis. This is for prevention of any infection gaining access to the baby. The second most important medication that you give to this lady is dexamethasone or betamethasone, the steroids. The steroids are used to boost up the baby's lungs, and they are given in 2 or 4 shots over a span of 24 hours. So that is very important. I mean, if somebody is like 3 to 4 centimeter dilated already, I would still say that they have a case for giving the steroids, because whatever little effect it might have on the baby's lung, the better. After the baby is born, the pediatricians usually give the baby surfactant, because that's what the steroids do. They mature the surfactant cells on the lining of the baby's lungs so that the baby can breathe normally when the baby is born. So after birth, the baby receives surfactant. Before birth, the mother receives steroids. Usually it is dexamethasone or betamethasone. Now, as I just said that, it takes about a 24-hour window for the steroid cover to be completed. So there is a medication called Tractocil or atosiban, which is proven to be, if we give them IV for 48 hours, it will delay the preterm labor. It will settle down the contractions for at least 48 hours till the steroid cover is completed. So that's a very, very important drug, the Tractocil or atosiban. It is tocolytic. Tocolytic means something that will prevent or stop the contractions. And it is given as a loading dose initially, and then a maintenance dose for 24 to 48 hours. After 48 hours, its role is not beneficial and it should be stopped. The third medication that we give is magnesium sulfate. Now, some studies also show that magnesium sulfate can be used in place of Tractocil or atosiban, but magnesium sulfate, why I'm mentioning it over here, is that a bolus dose of 4 grams of magnesium sulfate IM is very good for fetal blood-brain barrier and fetal brain maturity and brain protection, neuroprotection. So that's given to the mother as well. And then the bottom 2 pictures are of dufaston and cyclogest. These are the progesterones that the mother may receive to delay the interval between diagnosis and delivery. Okay, so if somebody is, say for instance, if somebody is coming at 19, 20 weeks and the cervix is shortened, so obviously that baby will have a less chance of survival if the baby delivers. So there is an option of a cervical cerclage where we put a stitch on the cervix. It's done as a minor procedure inside the operating room after giving anesthesia to the mother. And there is a risk of miscarriage after that. There is still a risk of preterm birth after that, but it can be done as an emergency cerclage in the best hope that it would prevent the cervix from opening or expelling the products of conception out. Okay, so what about the mode of delivery? Like, I mean, say for instance, you did everything and still now the lady is delivering. So what about the mode of delivery? So it's purely depend on a case to case basis. What we normally do is that if the presentation is not cephalic, if the presentation is a breech, if it is a small baby, then a cesarean section is warranted. However, if it is extreme preterm, say for instance it is 20 weeks or 21 weeks, then the experts say that the discretion is yours, because you need to explain to the parents the advantages of cesarean over a normal delivery. Or if the baby does not survive, and then you are again doing a cesarean, so she would have a big procedure, a major surgery, plus the baby did not survive. So every case is so different. So basically look at the presentation. If it is breech, or if it is transverse, or if it is oblique, then a cesarean is warranted. If the baby is cephalic, and if the baby is above 34 to 35 weeks and everything is going on fine, then normal delivery can be contemplated. If there is any additional maternal comorbidities like preeclampsia or a twin pregnancy or a triplet pregnancy, then also your rationale of doing a cesarean section would be much higher. So all the preterm deliveries, about 70% of preterm babies end up having a C-section delivery. The most important thing is where you're going to deliver this baby, because it's not just about the mother. So say for instance, if she comes to you and your neonatal intensive care cannot accept this baby, then you may need to transfer the mother out, which is called an in utero transfer, or you may need to transfer the baby out once the baby is delivered. It's called ex utero transfer. So you have to be in liaison with your multidiscipline of pediatricians and neonatologists at the same time to make sure that you're making a safe plan for the mommy and for the baby. So this is something like an infographic, and this is given by the National Institute of Clinical Excellence, the UK, which says what to do for everybody. And this is sort of an infographic that is stuck on the wall in each labor room, in terms of safety. So it just gives you an algorithm of what to do. So say, for instance, if somebody's symptoms are suggesting preterm labor, then you examine her. And then if she is less than 30 weeks and you are suspecting preterm labor, you admit her and you give her tocolytic, you give her antibiotics, you give her progestogen, you give her steroids to boost up the baby lungs, and you liaise with the neonatal intensive care unit, and so on and so forth. If somebody has broken her waters, which is PPROM, again, offer antibiotics to her. And studies have shown that erythromycin is a better antibiotic for PPROMs. So again, that's very important that you understand what way, because every woman will have a different and individually tailored birth plan, individually tailored management option if she goes into labor. So this is just an algorithm that I have put in on the slide for you. Okay, so what are our take-home messages? The most important thing is that we have a fetal fibronectin test, which can be done on a bedside, and we get a result within 5 minutes. So that can give you a conclusive answer whether or not somebody is in preterm labor or not. We have the cervical length test. So again, ultrasound is a very, very useful tool. We admit the lady and give tocolysis with atosaban or Tractocil for 48 hours. We give antibiotics. We give magnesium sulfate. We do a steroid cover, and we plan a delivery. Please remember that there are a lot of other factors, risk factors associated with the preterm birth. So social and economic characteristics, like if it's a teenager or a lady above 35, certain races have more predisposition to preterm labors. Any previous history of prior preterm birth, any infection, any history of twins, triplets, or more, and illicit drug abuse or alcohol abuse or cigarette smoking or stress factors. So you have to have a proper history in such cases, which is very important. So this educational activity has been supported by JSMU Anna, and that's my email address at the bottom if you need to ask me any questions, because this is a recording that we are doing. And once I've finished this presentation, I'm going to show you a short video of a parent who has just gone home after her preterm premature twin delivery. So I want you to empathize with the parents, what goes on as a thought process, and how their life is turned upside down and so on. So have a look at this video.
So we had the babies obviously by Caesar, and then they were taken straight away to the ICU, which there's no cuddling, there's no happy affair where they lie on your chest or anything. They showed them to me and they were off. We were very happy to have a girl and a boy, so that was fantastic. We didn't know what we were having. We were obviously due roundabout in the middle of November, and I went into labour at 7 months, 31 weeks. And unfortunately, there's nothing you can plan for. Because I went into premature labour, it was very unexpected, and we had the babies on the day that I went into labour, so there was no opportunity to do any planning. They were in the ICU for 6 weeks after that. So in that way, it was a little bit of space to get nurseries ready and all the silly things that we hadn't even bothered doing up till that point. They tell me that I went into labour because the babies had an infection. It was obviously something that they only found out afterwards. But they do say that you wouldn't go into labour for no reason. It wasn't because I was too big or was huge, but it wasn't because I was too big. They only can deduce that because both babies had infection markers, but they don't know what the infection was. So they just pumped them full of antibiotics to get rid of the infection. But when they came out, they were sick. They had a variety of complications. It was a really rough road. Because they'd had cortisone injections at 28 weeks, their lungs weren't too bad, but Jamie's lungs struggled in the beginning, so we had a few scary moments with that. And then with her, she had some really awful. She had 2 pulmonary hemorrhages, which means she was bleeding into her lungs, and that was terrible. They phoned us at 5 in the morning to authorize blood transfusions and told us the stories afterwards about how it was very, very close. So we're very fortunate to have her. I had to go in. It took a while for them to breastfeed. Fortunately, I had lots of milk, but you start off with expressing, and then they feed them through a nasal tube, and eventually, I think probably after 3 or 4 weeks, they started breastfeeding, and you start learning how to tandem breastfeed, which is very interesting, but necessary, because otherwise you'd spend your whole time feeding. And yeah, so slowly but surely they were growing, and it was exhausting because I had to. By the end, I was going into the hospital 3 times a day, and I've got a 2-year-old as well. So dividing my time between her and the hospital was quite stressful. But it was so worth it after all of the trials they'd been through. It was just good to see them getting happy and healthy. Yeah. My experience at Constantiaberg was amazing. I was so fortunate. They made what would have been, what was a really, really awful experience. They made it so much better than it could have been.